Hello everyone, this is Dr. Santosh. Welcome to Dr. Santosh Medhavi University. Please subscribe the channel, like the video and press the bell button so that you will get notification. Today we will be talking about very important topic that is called homocystinuria and homocysteinemia. So we will see the difference between this homocystinuria and homocysteinemia in the coming session. So we will start this class with case. So the case is 18-year-old boy was rushed to emergency with a severe retrosternal chest pain. The patient parents told that the child already had undergone lens replacement surgery of both eyes. So this is very important point. Lens replacement surgery has already been done. The patient has lower height and weight in comparison to children of his age. So there is retardation, growth retardation is there, and the distorted chest that look like a marphonoid habitus. The patient's lipid profile came to be within a normal limit, and patient cardiac troponin T level was found to be 32 nanogram per liter. Now ECG was very consistent with the myocardial infarction. His homocysteine is very high, about 100, more than 100 micromole, and normal is less than 15 micromole per liter. Methionine level was also very high, so it is 400 micromole, and normal is less than 30 micromole. So what is the diagnosis? What are the laboratory findings suggestive of the disease? And then explain the biochemical pathway and discuss the laboratory finding involved in this type of disorder. So there are many types of homocystinuria. So four types of homocystinuria. We will talk about the biochemical pathway related to those all homocystinuria, and we will also talk about the homocystinuria that is associated with this case. So this case is the case of classical homocystinuria. We will talk about that classical. This is the most prevalent type of homocystinuria, most common homocystinuria, classical homocystinuria. This is the case of classical homocystinuria. There are other type of homocystinuria. We will talk about the biochemical pathway and laboratory finding of other type of homocystinuria also. And what are the laboratory? We will talk about the laboratory finding that are actually used to diagnose this classical homocystinuria. Then what drug would have prevented this episode of this patient? So drugs, we will talk about the drugs, what that is being used for such patients. Now let's talk about these two conditions, homocysteine and then homocysteine. So homocysteine is a single amino acid, so it is converted from methionine. This is homocysteine, and this is homocysteine. Homocysteine is made up of dimer of this homocysteine, and this homocysteine appear in blood because it has got two carboxy group. It is more soluble in blood. This appear in urine, and that is why homocystinuria. And this type of homocysteine, they are measured in blood, and this is homocysteinemia. This hyperhomocysteinemia, that this is called hyperhomocysteinemia. The spelling is different, and with spelling the molecule is also different. One is monomer, other is dimer. Now let's talk about this first, classical homocysteinuria, which is very prevalent, actually very prevalent in Qatar. This is most common type of homocysteinuria that occurs in 1 in 300,000 cases. So this homocystinuria occurs in 1 in 300,000 cases. In Qatar, the 1 in 1800 cases. You will see the case. So this is the most common type of homocystinuria. And classical homocysteinuria, this homocystinuria, as all homocystinuria is, this is autosomal recessive disorder. This is the most common form of homocystinuria, called classical homocystinuria, and it is caused by cystathionine beta synthase enzyme. We will talk about the pathway of this enzyme. Actually, I have also talked about the pathway in previous 4 lectures. This is actually last lecture in the series. Homocystinuria, based on level, you can mild homocystinuria, moderate homocystinuria, and severe homocystinuria. And classical homocystinuria homocystinuria is severe type of homocystinuria. You will see homocysteine level is very high. It is more than 100 micromole per liter. Other find so this the common finding of this homocystinuria is failure to thrive and growth retardation. So eye is involved, bone is involved, brain is involved, and cardiovascular system are involved. So in eye, what will happen is in eye there is generally downward displacement of lens within in between age of 3 to 5 years of age. So there will be downward displacement of lens between age of 3 to 5 years, and there will be myopia because of that short sightedness will be there. And then bone, so bone will have osteoporosis, and the patient will have marfanoid habitus. Marfanoid habitus means the body will be long and thin, and the chest will have pectus excavatum. So these are the finding very similar to Marfan syndrome. That is why it is called Marfanoid habitus. So bone will have osteoporosis and Marfanoid habitus, and lens displacement is also there in Marfan syndrome, but the lens displacement in Marfan syndrome is upward. Here you can see lens displacement is downward. And brain, there is mental retardation in 50% cases. There is mental retardation. So mental retardation is associated with this disorder. A very most important finding is cardiovascular involvement. So cardiovascular system involvement. There is thromboembolic episodes that is seen in such patients, and this seen within first decade of this patient's life. So what will happen is this serious morbidity, this thromboembolic episode is the major cause of morbidity and mortality. The patient dies because of this uh, thromboembolic episode. So this patient has eye problem in eye, that is dislocation of lens, osteoporosis, Marfanoid habitus, brain has involvement of brain, mental retardation, and psychiatric disturbances are there, and serious thromboembolic episodes are there. Now we can see these are you can see the displacement, downward displacement of lens in such patients, a downward displacement of lens, and because of thromboembolic episodes, these patients will have myocardial infarction in early age within 1 decade of age, and there these patients within 1 decade can have stroke, and then deep vein thrombosis. The thrombosis will occur in deep vein, that is beneath gastrocnemius muscle, and those will cause deep vein thrombosis and swelling of leg, if you can see here, and pectus excavatus will be seen in, and this is very similar to Marfan syndrome. Thin slender body will also be seen. So this is actually the case of Marfan syndrome only in order to show the Marfanoid habitus, that is also present such type of Marfan feature which seen in homocystinuria patients. And this thromboembolic episode is a very life-threatening cardiovascular complication, and that affect coronary artery, renal artery, cerebral artery, these all arteries, and that is within first decade of life, and that is this is the major cause of morbidity and mortality. Now let's come to the laboratory diagnosis. So laboratory diagnosis, if we see this for this cystathionine beta synthase deficiency, that is classical homocystinuria. First is classical homocystinuria. If we see in classical homocystinuria, both are high. Methionine, homocysteine, and methionine both are high. But if we see in other non-classical homocystinuria, we will see reverse trend. Homocysteine is only high, methionine is low. If you can see everywhere, homocysteine is high and methionine is low. This is very important finding that is helpful to separate this classical from non-classical. This classical has very high methionine and homocysteine also, but non-classical they have low methionine and very high homocysteine. Now this non-classical, there are three types of this non-classical homocystinuria. If we can see this, this is first is because, second is because of, after this first, this second is because of MTHFR, that's methylene tetrahydrofolate reductase enzyme deficiency, and we can see homocysteine here will be very high but methionine is low. Now third type of homocystinuria, we will see methionine synthase deficiency is there. Especially methionine synthase deficiency occurs because of this cobalamin metabolism deficiency. The protein cobalamin that is involved in cobalamin metabolism, intracellular metabolism of cobalamin is cobalamin C protein mutation occurs generally, and because of this methionine synthase enzyme is deficient, and in this condition also homocysteine will be very high but methionine is very low. But one extra thing will be seen, one extra molecule will be seen in the blood, one extra findings you will see in the blood. So this is because of methionine synthase vitamin B12 dependent enzyme deficiency. You may find methyl associated methyl malonic aciduria, and along with that because of vitamin B12 deficiency there can have megaloblastic associated megaloblastic anemia. So if there is vitamin B12 associated problem, there will be more presentation in addition to this homocystinuria. And this fourth type of homocystinuria can be because of vitamin B12 malabsorption or deficiency. And here the same thing, you see the homocysteine level is very high and methionine level is low. And you can see same thing here as methyl malonic aciduria and megaloblastic anemia. So we have seen first is cystathionine synthase deficiency, and this enzyme is dependent on vitamin B6. So classical homocystinuria is dependent on vitamin B6. And second type is this is folate dependent. So folate dependent homocystinuria. Third and fourth is vitamin B12. So three vitamins are involved here. Vitamin B6, if you add to 6 it will become B9, and B9 is folate, and then if you add to that 9 it will become 12. So B12, B6, B9, B12, it will be easier to remember. So these three vitamins are involved in homocystinuria. And how do we separate this classical homocystinuria from non-classical homocystinuria? The homocystinuria, and that is caused because of folate metabolism defect and cobalamin metabolism defect associated homocystinuria through this finding. This has both increased but they have reverse. Homocysteine will be high, methionine will be low. Homocysteine will be high, methionine will be low. Homocysteine will be high, methionine will be low. And in vitamin B12 there will be association of methyl malonic aciduria as well, plus megaloblastic anemia. Methyl malonic aciduria plus megaloblastic anemia. I have done first video on trans-sulfuration reaction, that is synthesis of cysteine as well as breakdown of methionine. Then I have done second video on this SAM, that is function of SAM. I have done third video on activated methionine cycle. I have done fourth video on folate cycle. So I have done this very detailed video on this pathway. You can go and watch those video if you want to know those all things in very detail. So let me explain this pathway. What will happen is, first this pathway this is called activated methionine cycle. What happens is this methionine, generally this is metabolism of methionine. So methionine will convert into homocysteine, this pathway. So what is the function of methionine? Is methionine, this methyl group will be transferred to form certain very important compounds, for example creatine and catecholamines. So this is very important methyl group, and that methyl group will be activated, and this is called activated methionine. This methionine will react with ATP and it will be transferred to ATP, and this will form S-adenosyl methionine, and S-adenosyl methionine is called active methionine, and this methionine will transfer methyl group to form compounds called creatine or catecholamines and many more in other compounds, important compounds in our body. After that this SAM will convert into SAH, S-adenosyl homocysteine, and homocysteine after hydrolysis it will form S-adenosyl homocysteine. After hydrolysis it will form homocysteine. Now this homocysteine can be recycled after remethylation. There is one pathway, and then second pathway is that this homocysteine will convert into cysteine. So this will have to understand. If there is problem in this pathway, there will also be homocystinuria. If there is problem in this pathway, there will also be homocystinuria. So homocysteine has two ways to go: this way upward and this way downward way. So if there is problem in downward way, there will also be problem. There will also be homocystinuria. If there is blockage in this way, there will also be homocystinuria. And this way is associated with vitamin B6. This way is associated with vitamin. What happens is this homocysteine will react with cysteine, and this sulfur will be transferred to cysteine carbon, and that is why this reaction is trans-sulfuration reaction. This reaction occurs in two steps. So now cysteine, this cysteine amino acid will react with homocysteine, and after it reacts with homocysteine, the compound formed is cystathionine, and this cystathionine is synthesized by one enzyme, very important enzyme, the enzyme that is responsible, the deficiency of which is responsible for classical homocystinuria. This enzyme is called cystathionine beta synthesis. This is vitamin B6 requiring enzyme. Now this enzyme converts this homocysteine plus serine into cystathionine, and now cystathionine will again convert into some compound. So cystathionine now convert into this sulfur group. From this group will be transferred to serine, and now this serine, after getting sulfur group, it becomes cysteine, and this compound will break and cysteine will be formed, and one additional compound is formed, and that is the carbon skeleton of this compound is derived from homocysteine, ultimately from methionine, and this compound is called alpha ketobutyrate. Actually this compound ultimately will go into, it will form propionic acid, and this propionic acid will form succinic acid in mitochondria. So this is the catabolism of methionine. Methionine will form homocysteine, where homocysteine will ultimately form propionic acid and cysteine. So this is also pathway of formation of cysteine as well as catabolism of methionine. Now here this two-step reaction is called trans-sulfuration reaction, because sulfur is being transferred. So what happens if there is blockade in this pathway? If this enzyme is deficient, what will happen is homocysteine will accumulate here. Homocysteine will not go down. Homocysteine will accumulate here, and because of that, what will happen? Homocysteine level will rise, and there is second pathway for homocysteine. It will go to this pathway, and ultimately this homocysteine will convert into this methionine. So methionine concentration will also be high, and homocysteine concentration will also be high in cystathionine beta synthesis defect. Now let's talk about this conversion of this homocysteine into methionine through recycle of homocysteine to methionine. So recycle of this homocysteine to methionine require one methyl group that has to be added to homocysteine, and this methyl group comes from the very complicated reaction of folate and vitamin B12. So at this step, folate and vitamin B12 both are required here for conversion of this homocysteine back to methionine. Now let's see the reaction. So this is the reaction. So actually methyl tetrahydrofolate is ultimate donor of methyl group, but this methyl group will be donated to this homocysteine through methionine, and this whole reaction is done by methionine synthase, and that is why folate is also required. Vitamin B12 is also required here, and if there is deficiency in vitamin B12 or folate, or if there is deficiency in the enzyme that metabolize this folate, there will be impaired conversion of this homocysteine into methionine. If there is no conversion, so if there is blockade in this pathway, homocysteine will rise here. Homocysteine will rise. But what about methionine? So methionine will not be there. Methionine will be low. And that is why in this vitamin B12 and folate associated metabolic disorder will have high homocysteine but low methionine. Now let's see, this enzyme deficiency is the most common deficiency in folate deficiency in this enzyme deficiency causes homocystinuria. The enzyme is called methylene tetrahydrofolate reductase. Actually what happens, this methylene actually folate, I have already talked in detail sources of carbon, one carbon group for tetrahydrofolate. So serine becomes serine, or serine becomes the source of this methylene carbon, and from serine this methylene carbon will be added to tetrahydrofolate. But what happens is this methylene will not be transferred, this methylene methyl group will be transferred to, this has to be transferred. So methylene will be reduced to methyl by this enzyme. If there is deficiency in this enzyme, this methylene will not be reduced to methyl, and if methyl is not reduced, so ultimately methylation will not happen and this reaction will not happen. And because of this, there will not be conversion of homocysteine to methionine, and therefore homocystinuria. And the same here, if there is problem with vitamin B12 metabolism, then also there will not be conversion of this homocysteine into methionine, and then homocystinuria. And that is why in such homocystinuria what will happen is homocysteine level will be very high, and homocysteine level here methionine level is very low, because homocysteine will not be converted into methionine. But in such cases homocysteine will accumulate and homocysteine will convert into methionine. That is why deficiency of cysteine beta synthase, that is classical homocystinuria, result in increase in both. So this is all about the pathway, description of pathway. I want to emphasize one more point. This is here I would like to tell this. So MC means methionine cycle, or AMC means activated this cycle is called activated methionine cycle or methionine cycle. One very important point I would like to keep here is folate trap. So in condition of vitamin B12 deficiency or defect in intracellular metabolism of vitamin B12, what will happen is this methyl group will not be transferred here at homocysteine. Then what will happen, this methyl tetrahydrofolate will accumulate, and this methyl tetrahydrofolate is not utilized anywhere in the blood, anywhere in the reaction. Only methylene can be utilized, methyl tetrahydrofolate is not utilized. That is why this methyl tetrahydrofolate level will be very high in blood, but it will not be utilized. That is why this is called a trap for tetrahydrofolate, and this trap is called folate trap. Because of this folate trap, the vitamin B12 causes, in vitamin B12 deficiency, megaloblastic anemia is there because of this folate trap only. So what is the cause of, so if we have to answer the question, what is the cause of megaloblastic anemia in vitamin B12? The answer is folate trap. What is the cause of vitamin B12 deficiency? What is the cause of megaloblastic anemia in vitamin B12 deficiency? The answer is folate trap. Now let's talk about the next thing. So this reaction I have shown, this is alternative reaction. If everything is failed, so there is one alternative reaction in our body, but for that we have to take this betaine in our diet. So what happens, this betaine is heavily methylated group, and this methyl from this group can also be transferred to homocysteine by a different enzyme called homocysteine methyltransferase. Betaine homocysteine methyltransferase. We actually utilize this reaction for treatment. We will talk about that. Now let's see the treatment part. So what happens in cysteine beta synthase? As we have seen, in cysteine beta synthase deficiency, there is rise of both methionine as well as homocysteine. If both are raised, so what will happen? So you give those patients methionine free diet. Methionine will always be there in diet, in their body, very in high quantity, so you avoid methionine. And because this methionine will not convert into cysteine, because this pathway of cysteine synthesis is abnormal, and that is why we supplement cysteine. So the diet devoid of methionine and we add cysteine. Here in such patients, cysteine becomes an essential amino acid. So we supplement with cysteine and then avoid methionine. And third, this is very important point. So the in question, in the case only, what the question was, what treatment would have prevented the condition? The answer is high dose of pyridoxine. So pyridoxine more than 50 mg, about 50 mg. So if we give pyridoxine higher than 50 mg in such patients, generally our daily requirement of pyridoxine is about less than 5 mg. But in this condition, pyridoxine is given in amount more than 50 mg. So that will treat such patients. Most of the cases are vitamin B6 responsive. Very few cases are not vitamin B6 responsive. But this cysteine beta synthase deficiency is vitamin B6 responsive. That is why this vitamin can prevent such conditions. So these are three treatment modality: avoid methionine, supplement cysteine, and give high dose of vitamin B6. So this is the most important homocystinuria. Now let's talk about this homocystinuria. As we know, it is because of deficiency of folate, and that is why we supplement folate. And I have already told you this alternative pathway of methylation is by betaine, and betaine supplementation can also help such patient. So betaine supplementation and folate supplementation. Now third is this. So here what will happen is cobalamin C is the problem. Here betaine is very important. So you supplement this patient with betaine, and you also give the vitamin B12, though I have not written, just supplement vitamin B12 and folate and betaine, everything, because folate is water soluble vitamin, will not be toxic. So you can give a bit more, but it will not be toxic. So folate, vitamin B12 and betaine are the treatment here. Now vitamin, when there is malabsorption of vitamin B12, just supplement vitamin B12 and folate. So here we see vitamin B12, folate and betaine are the treatment option. And this is the most important. You must remember everything about this cysteine beta synthase deficiency. Just in order to understand the whole pathway, if you understand the whole pathway, you will understand this all thing. You don't have to remember that much. So this is all about homocystinuria. Thank you for watching. Please don't forget to subscribe the channel, like the video, and press the bell button so that you will get notification.